sometimes you inherit cases that are done elsewhere and done in a particular way that you're not really in agreement with. And you may think out of the box. So this is one such case. So I'll just take you through it. Right. So this is lady who came to me with this X-ray. You can see it's a GT fixed open. This was the MRI that you can see here. You can obviously see that the fragment's not back to its position on the CT scan. I do it arthroscopically in a B chair position, multiple portals. The first thing is to identify the screws that need to be removed, and using LP needles to get your portals in the right position. The screws are removed, and be careful about not displacing the washers. Following that, once the footprint is prepared, you need to see whether the fragment sits back onto its footprint. And then I use standard anchors, 2 medial row and 1 lateral row, to basically take bites to the cuff tissue beyond the GT fragment, for the GT fragment to indirectly get reduced to its footprint and ultimately unite. So the lateral row acts as a double protection to what you're doing and gives better compression at the end of it. Once this is done, let's go into the arthroscopic part of it. The first part is there's going to be a lot of fibrosis. So get rid of all that fibrosis by using your shaver. Visualize your screws adequately well. Once you've done that, clear out the tissue around your screws to visualize the washers properly. Elevate the washers using a bone awl or something like that, and then you could make portals in the direction of the screw heads, engage your screw heads with the screwdrivers. Once that's done, hold the washers while pulling out the screw so that you don't lose them anywhere in between. You do the same thing and repeat it on the second screw. Sometimes it may just be loose, and you'd see when you use your osteotome, it automatically comes out on its own, and you don't really need to screw it out. And you can see that this gradually the washer and the screw gets disengaged and is taken off. Now we proceed with the definitive fixation. It starts with a good subacromial decompression because you need to introduce your instruments beyond the cuff. So you may have to use a combination of shaver, burr, etc. Once this is done, you've got enough space to pass instruments into the subacromial space and take your bites to the tissue. This is the footprint. You should see it end on. Once you see it adequately well, you can clear the fibrous tissue that surrounds it for better healing of the fragment back onto its footprint. Check reducibility, very important here. You need to put it where it should be. Once that's done, you, of course, go in with your anchors. Use a standard double-loaded anchor on the extreme ends of the fragment. Once the first anchor is put in, it's important to pull your GT fragment while taking the bites beyond the fragment, because the fragment may be rather large. So you do not want to comminute the fragment further. You want to take bites in the cuff tissue beyond the fragment so as to indirectly reduce it to where it has to go. You can see in the second anchor going in, and the suture lasso is a great device. I don't like the scorpion when it comes to GT fixations because the fragment may be rather large. So then you take bites. Use your PDS used to shuttle the number 2 fiber wires through the cuff tissue beyond the GT fragment. And you continuously do that. You get as many bites as possible with regular intervals between them, which could be about 0.5 millimeters or so as to cover the whole fragment. You may have to go slightly inferior also depending on the size of your fragment, as you can see here. So once this is done, like a standard rotator cuff tear, you tie multiple half hitches and simple knots, and the other ends are then delivered once you've tied your multiple half hitches, as you can see here, to basically load onto your lateral anchor that's pushed in just inferior to the GT footprint so that you have no impingement at the end of the procedure. Once you've done this, definitely check whether the space is adequate in the subacromial space and do a subacromial decompression, because ultimately you want no impingement. This was the main GT fragment, 6 months, and this is what you can see. She had good function later on, and now she has full movement, and you can see ultimately the GT fragment unites. Thank you.